The treatments for BRAF-mutated, V600E mutated colorectal cancer have evolved over the years. Early studies suggested really very little activity with single-agent BRAF inhibition, or even BRAF combined with MEK inhibitors, in contrast to other tumors like melanoma. Some very important finding was that part of this is due to an adaptation of the tumor, that as soon as the BRAF and MEK inhibitions are applied, that there can be upregulation of other growth factor signaling, and including the epidermal growth factor receptor, EGFR. So it was found that it was not just the BRAF and MEK, but the addition of an EGFR inhibitor to blunt that feedback that was most critical. This is an important thing to understand because we know that response to EGFR inhibitors alone or with chemotherapy and with patients with BRAF V600E mutations are fairly low and rare. But that when we combine with a BRAF and MEK inhibition, we uncover this sensitivity to EGFR. So the development of BRAF inhibitors has been paired now with EGFR inhibitors. And the progress that's being made are really looking at combinations that include EGFR and BRAF inhibitors.
One of the key reasons that BRAF V600 mutant colorectal cancers don't respond as well to BRAF-directed therapy is due to what we call adaptive feedback resistance. And what this means is that when you give a BRAF inhibitor or a BRAF and a MEK inhibitor combination to a BRAF V600E colorectal cancer patient, you shut down the pathway very briefly. But when you do that, you actually lose a number of negative feedback signals that actually suppress activation of the wild-type MAP kinase pathway by receptor tyrosine kinases, particularly the epidermal growth factor receptor, or EGFR. And so what we have found is that unlike other cancers like melanoma with BRAF V600 mutations, in colorectal cancer, when BRAF inhibitors are applied, you trigger this very robust feedback loop. And EGFR and other receptor tyrosine kinases can actually reactivate the BRAF pathway within a few hours and certainly within a few days. And so what we've learned in trials where we've actually taken biopsies before treatment and during the first few weeks of treatment is that these therapies are not suppressing the target pathway the same way they are in other cancers and to the degree that we believe we need for response. So a lot of the current therapies are actually looking at more optimal ways to shut down MAP kinase signaling, either by adding other inhibitors of the MAP kinase pathways, such as MEK inhibitors to BRAF inhibitors, or actually targeting these very feedback loops by targeting EGFR and blocking EGFR signaling, which is how these cancers restore the pathways. So over the last few years, we've seen a number of clinical trials looking not just at BRAF-MEK inhibition, but at BRAF and EGFR inhibition alone. And more recently, we've seen trials actually looking at all three together, including BRAF, MEK, and EGFR as a triple combination. And one such study using dabrafenib, trametinib, and panitumumab was actually published early last year, showing an initial response rate of about 32% with a confirmed response rate of 21%, and showing much better pathway suppression in on-treatment biopsies relative to some of the doublet therapies.